Thank you to Angelica Vance, one of our Grow Your Biz chairs, and for your greetings and being our gracious host while the speakers were in the green room, along with myself and the moderator getting sound checks with the technical team. Good morning or good afternoon, wherever you are. I'm Barbara Mowat, creator of Accelerate, and I'm delighted to welcome you to today's Humanizing Healthcare session. It is nice to welcome back many of you who are part of our first 3 Accelerate events. Please note that all sessions are live and recordings are not available at this time. Throughout our series, as so many of you have experienced already, we will be virtually using 3 technologies: Hubcast Media, the producers of our series, as you'll notice today, EventMobi, our social platform, and of course, Zoom, where all of you are now sitting back with a refreshment, listening, learning, and networking, and of course, writing down lots of notes. Of course, Accelerate 2021 would not be possible without the support of our presenting sponsor, BMO Bank of Montreal, the 3rd year they have supported Accelerate, as well as being the founding partner and developing partner of our Grow Your Biz advisory boards. Export Development Canada, Public Services and Procurement, National Brokers Association, Bloom, TELUS, plus the many other sponsors and alliances that were on the rotating slides as you were entering the Zoom room. We also welcome MasterCard to our sponsor list. Accelerate is also pleased today to have Devonshire Dementia Home from the UK as our host for Humanizing Healthcare. The home is owned by Anar Mengalji, one of our members from our Grow Your Biz Fellowship boards. Anar was honored in 2018 when she received an honorary doctorate from the University of West London for her work in dementia. She has developed a unique dementia model which is incorporated into daily life at the Devonshire. Anar believes, in a quote from her, "Her best teachers have been the residents she has had the honor of caring for." Thank you, Anar and Devonshire, for being our gracious host today. Accelerate will continue to feature special hosts, along with thought leaders and international speakers, to focus on new ways of thinking. You will continually be inspired by innovators, disruptors, visionaries, activists, and creative entrepreneurs like our all-star panel today. Stay tuned, though, for April and May sessions. Highlights will include empathic leadership is good for business, sustainable solutions, global competitiveness, build your resilience, we empower you in SDG challenge featuring global winners, and much, much more. It is now my pleasure to introduce to you Dr. Daryl Plekas, the moderator for today's session, someone I truly admire and I call a friend. Daryl is a first-rate educator and leader, always persistent, a visionary, clever, and motivated in search of the better. He is Professor Emeritus at University of Fraser Valley. His long career has been extensive, including being Speaker of the Legislative Assembly of British Columbia, 2 terms as MLA for the riding of Abbotsford South as a Liberal candidate. And during those terms, he served in various capacities, including parliamentary secretaries to the Minister of Justice, Minister of Health, and Minister of Social Development. He is a recipient of numerous awards, including UFV's Teaching Excellence Award, the Innovative Learning and Technology Award, the Order of Abbotsford, the Canadian Centre for Substance Abuse Award of Distinction, the British Columbia Lieutenant Governor's Award for Public Safety, and Queen's Jubilee Medal. He is the author of books such as The Essentials of Leadership in Government. The list can go on, but this is why I was honored to have him accept to be the moderator of Humanizing Healthcare. Welcome to everyone, and enjoy the comments from our all-star panel, and make sure you take lots of notes because this will not end just today. It'll carry on. To you, Daryl.
Thanks very much, Barbara. And hello, everyone, and thank you all for joining us today. Before I start, I'd like to note that I'm joining you from the beautiful province of British Columbia, and specifically the territory of the Stolo First Nation. And it is with great humility and respect, I wish to acknowledge their traditions, culture, and heritage. I have to tell you that in getting ready for this event, I had the good fortune of speaking at length with each of our 6 panelists, and wow, what an impressive group of people. I kept saying to myself as I was talking to them, do I ever wish that all of you could have been listening in on those conversations? They're all doing important work, leading edge work, and they all have so many valuable things to say about how we can improve our healthcare efforts. Those prep calls were very much an inspiration to me, and I hope you will be inspired by what they have to say today. We all know that we definitely need that inspiration right now, and we will be needing it for some distance into the future. We also know what the starting point is here. Our governments are already spending 40+% of their budgets on healthcare. And there's every indication that unless we start doing things differently, start getting creative and innovative, that percentage will increase significantly against a declining capacity to pay for it all. All we need to do is some quick math on this. Again, for example, we look at the province of British Columbia, and we have right now about 750,000 people over the age of 65. That's expected to double by the year 2030. You don't have to know very much about math and money to know that that's a very serious situation, because of course that group is the hugest drain on health resources. So it's why our panelists are so valuable, and in fact, I would argue why they are so necessary. So let's get started. And if I may at the beginning here, give a reminder for those of you who might have questions, if you can submit them at any time, but we'll certainly try and address as many of them as we can once we've had an opportunity to get through all the questions towards the end. And what I'd like to do now is I'm going to interview our 6 panelists one by one. And I'm going to start with a very short presentation, a review of their bio. I'll leave it to you, if you will, to look online at the very extensive bios for all of them. I think if I was to go through all of their bios in any kind of detail, this would gobble up 2 hours here. So I'm going to try and keep this brief and just focus on a few highlights, and then as a way of introducing them, and then get right into the questions. Our first panelist is Laura Tamlin-Watts. Laura is a lawyer, an advocate, a researcher, and a media commentator. She's on the executive and is in fact the past chair of the Canadian Bar Association's National Elder Law Section, and she is a board member of the National Initiative for Care for the Elderly. She also teaches at the University of Toronto, where she is also a fellow of the Institute for Life Course and Aging. She has previously served as a chief public policy officer at CARP, and you'll know that as the Canadian Association of Retired Persons, and as the national director of the Canadian Centre for Elder Law. Welcome, Laura. Laura, as we all know, no group has been more affected by the pandemic than seniors in long-term care. And that effect has taken us beyond the impact of the pandemic to consider the need to make some more pressing changes on that front. What, in your view, are some of the more significant changes we need to make? And what do you think we need to do to make those changes?
Thanks very much, and bienvenue à tout le monde. It's lovely to be part of this conversation today. The issues that are drawn out over the course of COVID-19 are not new issues, but there has certainly been a spotlight upon them in a way that perhaps has never before been seen, starting, as you said, with the long-term care homes, but also looking at the 92% of all Canadian seniors who will never end up in long-term care. At a high level, some of the issues that we are really struggling with is, what is the future of aging in place look like? We again are thinking about what long-term care looks like specifically. And I know there are some people who say, we don't need long-term care in the way that it is. And that simply isn't true. We will always need some places to provide 24-hour, very high level nursing supported care. But we need to make sure that that is not institutionalized, but is home-like and meets the well-being of people so that they can live in those situations in the way that is both emotion focused, that's integrated in social care, and has those walls of long-term care home not be walls that stop community and engagement. So we need to break down the proverbial walls as we're making sure that the built environment, the physical space of long-term care is modern, accessible, and integrated. And then at the same time, we need to make sure that those 92% of Canadian seniors are able to age in place well. This is no surprise to anybody that it means a more robust system for home supports. Anyone who has ever tried to arrange home care will know that it is overwhelmingly private pay. It's incredibly expensive. It's difficult to manage and organize. And yet we have more need, not less need, for long-term care and home care spaces. So we're not investing in the places and spaces that we need to invest in. And nothing I am saying is new, but again, it has been exacerbated by the COVID-19 challenges. And the last piece I'll just conclude on is about drawing out that notion of social inclusion. We have all experienced, some of us for the first time, what it means to be apart from each other, physically, emotionally, socially apart. And I know that some of the challenges everyone is facing is amplified. If you're an older person, you're a person with vulnerabilities or challenges with moving around in transportation, and has never been so marked as during the time of COVID-19 and long-term care, where we have seen people in fact locked up, and there's no other way of putting it that's prettier, locked up, some for months on end in their individual rooms with no contact from the outside and very little contact from those people for whom they have a community within long-term care. So social inclusion is a piece that we need to be thinking about much more robustly, and remembering COVID-19 is an extraordinary circumstance, but it's not unique. Every year in long-term care, we have influenza. We struggle against Legionnaire's disease. We've got C. difficile. We're working around the influence of bacterial pneumonia. So these are not unique circumstances. We need to make sure that COVID-19 is the springboard for change and not the end of the story.
Well articulated, Laura. Now, if I might ask you, one of the more distressing things that has come to light and has been exacerbated by the pandemic is the matter of loneliness and social isolation for so many people, in fact, here and elsewhere in the world. In fact, I notice in the UK, for example, as unbelievable as it might seem to many people, they're worried enough about this that they have now appointed a minister of loneliness. Do you think we would be helped by having one here in Canada?
Yes, I do. I think when we're looking at where some of these issues live, the answer is politically, they don't live anywhere. And where you do not have a government focus, you do not get investment and you do not get engagement. So I think the United Kingdom was really forward thinking. Loneliness is exacerbated by a number of social conditions, right? So if you have episodic disabilities, or you've got challenges with transportation, cognitive impairment, or just plain ageism, you're going to see more in terms of concerns around loneliness. That may happen as well if you lose a life partner, or you end up moving to a different community or even a facility. These are areas that we have these transition points that disengage us from our social networks. Interestingly, our Canadian research talks about where loneliness is also experienced at a higher level, which is in our younger years. And so we know that teens and people in their 20s have also very high degrees of loneliness and social isolation. That may not be intuitive for people, but it is important and evidence-based. Came out in August 2nd, I think it was 2018, a really important report from Stats Canada that drew out some of these pieces. We know that some of the opportunities are around intergenerationalism. We have hyper segmented our populations, and opportunities to have something like a minister for loneliness will indeed provide greater opportunities to think about how intergenerationalism and social connections can break down some of those ageist barriers and bring us together at a time where we've never needed it more. Is it the only answer? No, it's not the only answer. There's lots of things that we can do about it without a minister for loneliness, but I do think it's an interesting way that the UK has brought to bear this epidemic of social exclusion.
That's for sure. Thinking about seniors in general, one thing people probably don't know, but you would not expect, is that Canada is unique in the OECD for not having a formal senior strategy. However, you produced something just this year which speaks directly to that shortcoming, a complete plan for aging in Canada. Well, that sounds like a huge, huge undertaking. Can you tell us a bit about this plan?
It was a huge undertaking, and one that our organization, CanAge, which is a not-for-profit pan-Canadian organization, we're nonpartisan, and we can act as a bit of a backbone and the voice for seniors. We thought that this is an area that we could really lean into. You know, we've had ideas of senior strategies floating around, and often very medically based, or they're very top down, or sometimes they're connected with certain governments. And so we thought that what we could do was to extract the knowledge that we already have in this country, the many, many dozens of reports, of commissions, the robust literature from health and social sciences, anthropology and psychology, engineering, technology, the built environment, and synthesize them. We also engaged in hundreds and hundreds of key stakeholder interviews across this country, coast to coast to coast, in many languages, to draw out the experiences of Canadians, rural communities, Indigenous people, faith leaders, and others. And we synthesize it together in what we call the Voices of Canada's Seniors. And I'll put that in the chat, but it's canage.ca/voices, canage.ca/voices. We organize it in what we call the 6 points in our roadmap. The Voices of Canada's Seniors stands for violence and abuse prevention, optimal health and well-being, infection prevention and disaster response, caregiving, home care, long-term care and housing supports, economic security, and social inclusion. And if you open those letters up, you'll see 40 specific recommendations on issues and very, very targeted recommendations, 135 for positive change, not just for government, but for communities, foundations, philanthropy, not-for-profit, business, and individuals to take those steps forward. So it really is a place that's the collective wisdom of what we need to have to make Canada more age inclusive.
Wow, just an impressive piece of work. Laura, when you think of the sheer number of people over 65 that we have in Canada, 10 years from now we're going to have relative to our population, as I alluded to in my introduction, you can't help but wonder, as I certainly do, what the impact is going to be on our capacity to provide the level of health and social services that we have today, and we're certainly going to need to have in the future. What are your thoughts on this? Should we be worried?
I think that this is an area that we've been in denial about for years. There's no surprise that our population is aging, and that longevity dividend is a good thing. It's not a bad thing. So when we're hearing these sort of tsunami type of apocalyptic demography, I think it's important that we give our head a shake. It's only negative if we think about as aging as negative. And it's not. It's a success story. We've doubled our longevity in 100 years. It is, in fact, the greatest indicator of evolutionary success we've ever had. But because we have such narratives tied up in the negative aspects of aging, it ends up with this narrative of burden and concern. Now, part of it is because we think about older people as losing economic and social value as we age, which is frankly nonsensical and discriminatory. But if you use that number of 65, which by the way was developed when the average age of death was 67, as a demarcator right now, nothing makes sense. And so this is an opportunity to refocus and re-understanding what an aging dividend means. My children have a life expectancy well over 100. And my grandparents who lived through the Depression and were very impoverished lived well into their mid-90s, right? So we need to unpack some of those ageist narratives and those supports. Having said that, the last year of life is the most expensive year of life. And most people live a long time. So when you're looking at what healthcare dollars are spent, they're spent in the last year of life, which we hope is old. Now, one of the other pieces I just wanted to draw out is that we fund acute care and don't preventive care. Things like vaccinations, which we've learned has never been more important. And that's why we did a major on adult vaccinations, finding that only about 3% of Canadian seniors are vaccinated for all the vaccines they're supposed to, and Canadian adults are only vaccinated 10% of what they're supposed to. So we can start shifting some of that broken bone narrative around acute care and stop trying to use those emergency resources, invest those institutional dollars upstream for active health and wellness, engagement, prevention, and supports. And we'll see that that negative narrative around aging and cost burden gets shifted into wellness and well-being. It's not something that's that hard. That's the other piece that I want to say. We actually know the solutions. We've done the math. The economics make sense, and people are engaged. What we have seen is a lack of movement on the political sphere combined with this ageist narrative, which is holding us back.
Special thanks for that, Laura. You know, you mentioned vaccines, and we've been hearing a lot about vaccines in Canada, as we all know lately. And we've all heard how important it is that seniors, and in fact, all of us, get vaccinated for COVID-19. But there's also been increased talk about the importance of getting vaccines in general. Just how well are we doing as a country on this front?
Terribly. We just reduced this major vaccine report, which you can find at canh.ca/vaccine report. And you will see that we gave Canada a D- overall for how we do for major vaccines. So things like influenza, which comes every year. We talked a lot about twindemics this year, pneumonia, thinking about things as well like shingles, incredibly painful, debilitating, and easily vaccinated against with a very, very effective vaccine, as well as things like tetanus, diphtheria, and pertussis, which is whooping cough. And what we know is that older people do not have at their fingertips adult vaccination schedules. We think about it as a thing for kids, and we fund it like a thing for kids. And yet, it actually is critically important that we get the vaccines that we need. And we don't just fund them, but we make them available, easily accessed. And boy, have we ever learned how important access is during the time of COVID-19. You can have vaccines, but unless they're out of the closet and into the arms of people, they're helping no one. And then making sure that the right information gets to the right people. Adult vaccinations are critically important. And what I hope is that we move from that D- straight up to an A. And how to do that, the steps are very, very clearly laid out, very doable. We can turn a switch and change that narrative this year and really do mass vaccinations. The last thing I'll say is one of the ways that we order and think about vaccines year to year is really upside down. So instead of saying, for instance, we know that we're looking for about 80% vaccine coverage for all adults for these common needed vaccines, 90% for seniors and people who may have other vulnerabilities like immunocompromised or people with disabilities and so on. So 80 and 90%. But we don't say, okay, we're going to order 80 and 90% of these vaccines. What we do is leave it to the provinces, and then the provinces go down to the public health units and then say, okay, tell us how much you think we're going to need. So I'll just give you one narrow example of Ontario, where the premier announced that everyone would have influenza vaccine that wanted it. And we were all could not quite understand what that meant was because it takes about 6 months to order influenza vaccine. And he had only ordered a maximum amount for 40% coverage. So there is no more global vaccines. Now, just today alone, they did a major announcement about Canadian in-country vaccine production with Sanofi. So there's perhaps some movement in that regard, but we need to order the vaccine and then give it to the provinces and the local health units to get it done. Otherwise, as we've learned from COVID, nothing gets better.
Laura, thank you so much for that wonderful collection of comments and answers. I'm going to talk next to Dr. Alex Mihelites. Alex is the scientific director and CEO of AgeWell, which focuses on the development of new technologies and services for older adults and caregivers. He is a professor in the Department of Occupational Science and Occupational Therapy and in the Institute of Biomaterials and Biochemical Engineering at the University of Toronto, with a cross appointment in the Department of Computer Science. He also holds the research chair in rehabilitation technology at the University of Toronto and at the Toronto Rehab Institute. In 2019, he was appointed U of T's Associate Vice President, International Partnerships. He's extensively published, internationally recognized, and is a Fellow of RESNA, which is one of the highest honors within his field of research and practice. Welcome, Alex.
Great. Thank you very much for having me.
Questions for you. I was going through your bio and I was wondering how in heaven's name do you do it all? My first question for you is, how can technology play a role in delivering healthcare, especially with vulnerable populations?
Yeah, so obviously that's the big question now that we're looking at. And, you know, and really the honest answer is technology already is healthcare, and it's already helping us in many different ways. And I think, you know, if we can take anything positive out of this recent pandemic that we're going through right now, is that technology is there and the infrastructure is being built for it to be part of health. Now, the one place though where the gap still exists though is applying that technology to support our seniors. As you heard from Laura, and by the way, I always hate following Laura because she's so great at getting these messages across, and then you get this poor, boring engineer coming to talk to you anyway. But you know, as Laura pointed out, you know, getting the services and the infrastructures to our seniors, whether they're living in their own homes, in retirement homes, or long-term care homes, is just not there. You know, AgeWell as a network across, you know, our about 1,000 researchers and 400 partners that are involved. We are all looking at how technology can play that role though and fill that gap. And so we have been developing technologies across a variety of the spectrum, anywhere from apps and handheld devices that can support older people and their caregivers, to more futuristic technologies such as smart home systems and even robots. And again, the truth is these technologies are here now. These are not things that are 5-10 years down the road or that we think are science fiction. These are technologies that are being developed and are actually getting very good data through some clinical trials being conducted at various universities and care facilities, that the efficacy is there.
Yeah, thank you. You know, it's all seemed to, so much has happened rapid fire in recent times. To what extent would you say COVID has impacted the way technology plays a role?
Yeah, so, you know, again, if we can take something positive out of the current experience, is that it is showing that technology is playing a role. And in fact, it is showing that seniors themselves are more willing to use technology in support of their own health and wellness and independence. AgeWell, back in 2019, we conducted a national survey of approximately 2,000 older adults to try to understand what their current use of technology was in all parts of their lives. We then conducted the same study just this past year, just to understand that exact question. How has COVID changed the role of technology in their lives? And what we found pretty much across the board is that our seniors were adopting technology more. They were more willing to use technology on an ongoing basis to do things anywhere from socialization with their friends and family to connecting with their their physicians and their clinical care teams, and even to online shopping. And what we found in that survey itself was approximately 2/3 of those individuals who responded that they use technology more was directly because of COVID itself. So taking that information, I think moving forward, we now have an opportunity. We're in the right time right now to be looking at how technology can play a larger role in the care of seniors. And that's exactly what AgeWell is trying to do right now, not just through the development of the technologies themselves, but by working with our policymakers and working with our regulatory system and with our current industry here in Canada to show how technology can play a role and what is the best way to get the technology in the hands of those people that need them.
Alex, I want to ask you a question now, which is an absolute direct hit on your very expertise, something you're known for globally. You're the world's guru. How are technologies like artificial intelligence and robots playing a role?
Yeah, things like artificial intelligence, robotics, smart home systems, wearable sensors, these are all starting to see a larger role in the types of technologies that are being developed and used with seniors and caregivers. Artificial intelligence, again, is one of those things that people, think, is very futuristic, things that we only see in the movies. But again, it's here, it's all around us already. We're already interacting with various artificially intelligent agents, so to speak, in our daily lives. What we're starting to see is that artificial intelligence is making its way into the technology and aging space as well, or what we call the age tech sector. And the reason for this is a lesson you learn very, very quickly, and I can say this as being a researcher in this field for many years, is that, when you've seen one senior, you've seen one senior. It is a very heterogeneous customer base. And so typically the one fits all approach that we take in developing technologies often does not work. And because of that, the technology needs to adapt itself. It needs to be able to understand the needs of the user and then change accordingly. And we want this to happen without having to have a caregiver or part of the care team or a nurse or whoever it may be to have to go into these technologies and adapt them on their own. We all know that they're completely overburdened. And when we get to Ron on this panel, he's going to probably tell you some fantastic stories about how technology has made his life easier as a caregiver. And that's because, again, of the intelligence that we're trying to build into these systems themselves. Robots, another fascinating thing. If I gave this talk 2, 3, 4 years ago, I would say robots are still not in the picture. Too expensive, too complex. They have no role in the care of seniors. That's completely changed now. We see the prices of robots coming down from millions of dollars to hundreds of thousands of dollars to tens of thousands to thousands, and now even in the hundreds. We're starting to see people use robots to assist older adults in cognitive activities, social activities, and common self-care activities as well. And actually what we're starting to see is even the application of robots in long-term care facilities, not interacting with the residents, but doing things like infection prevention and control. Quite easily, we can have a robot, just imagine, a robotic vacuum cleaner, but for infection control, constantly roaming the halls, the rooms of long-term care facilities in other places, in other homes. That will then help to hopefully reduce the spread of infection in the future.
Alex, one of the things you said, which is so profound, every single person is different. It doesn't that, and of course that's a wonderful perspective to have on everyone, but doesn't that make it even more complicated when we talk about applying technology and particularly artificial intelligence?
Yeah,
it seems to be at odds.
Yeah, and that's a great point, and that is why this field of age tech is quite complex, and we see many startups and many companies fail in this area because they come with that notion of not understanding the population that they're designing for, and they're all coming in with fantastic intentions, and I would say 90% of the startups I meet with start off with the same kind of comment that they have an elderly parent, they have a grandparent that's providing care for, they know someone with dementia or Alzheimer's disease, and they want to help that person. The problem is the solution for that person is not going to work for the other person, perhaps. And that's why we really need to take the time to understand the population moving forward. And AgeWell as a network, because we're coast to coast to coast, we have approximately about 5,000 older adults and caregivers that are involved in the network's activities, right from the management of the network to being part as equal researchers in the projects themselves. And that is something that we completely insist on, that you must have an understanding of the population you're designing for, and they must be active contributors to the development and the design of these technologies.
The question that comes up always when we talk about technology is the matter of ethics. And what do you see as some of the ethical issues in using technology in this role?
Yeah, there's a lot of issues that are brought up. Primarily a lot of people are concerned about privacy and security, obviously, of the data being collected. Myself personally, I tend not to worry too much about the security and privacy side. That's being worked on in several other fields that can be easily applied in the age tech sector. And the other thing we also need to keep in mind is you're never going to build a system, no matter whether it's age tech or a bank machine, that's 100% secure and private. And these are things that we need to be part of the education when we talk about the new technologies that are coming out. In terms of some other ethical issues, obviously, is around cognitive impairment. We're seeing a lot of work, a lot of technologies being developed for people with dementia to help them with their self-care activities, to help them remain as independent as possible in even the most basic activities, such as making themselves a cup of tea or brushing their teeth in the morning, and also in terms of reducing social isolation. Well, the ethical question there is obvious. Who makes the decision on which technology is best for that person, or whether technology should be used at all? We also run into the ethical question around, well, what is the sharing of care between technology and perhaps the family caregiver or the clinician in long-term care home? Where and how should technology be, quote unquote, replacing some of the activities and duties of these human caregivers, and where should they not be? Now, the unfortunate thing right now is we're seeing a lot of robots being designed to do things like have social interactions with residents in a long-term care home, or to sit down and play games with them, or to keep them occupied through various types of leisure activities. And unfortunately, we're not focusing them probably on the activities where we want them to be replacing live people, and that is in infection control and prevention, in cleaning, in doing those really more medial tasks that are difficult for many caregivers to perform, often lead to their own injuries, and probably are just very, very difficult with respect to mental health. I'd much rather see the technology doing those kinds of activities and allowing our family caregivers and our clinicians and staff sit down and actually have that social time and actually have some fun with their residents at the same time.
Alex, we're so lucky to have you doing what you do, and I love your perspective. It's obvious that you put people first, and as much as you are a renowned scientist, it's science afterward. Thank you again.
Great, thanks for having me.
Our next panelist is Ron Bellino, and Ron is an active advocate for dementia caregiving, aging, and research communities. Being a caregiver to his father, who lived with Alzheimer's for 10 plus years to age in place at his home in Toronto, Ron utilized technology, community, and access to research to support his family's life to live well as best as possible. He is a leading member of AgeWell Canada's Technology and Aging Network, where he chairs the Older Adult and Caregiver Advisory Committee, and he is also an advisor to several organizations. And I'm just going to mention a few of them because it is a very, very long list. One is the Center for Aging and Brain Health Innovation at Baycrest, the City of Toronto's Senior Strategy Accountability Table, and the Center for Addiction and Mental Health in Ontario, the Transitional Research Program at the University of Toronto's Faculty of Medicine, where he is a mentor in residence and patient engagement. Ron is the recipient of the Age Well 2020 Honorary Fellows Awards. Congratulations on that, Ron. And again, it's just amazing to see the huge volume of activities that you're involved in. I don't know when you sleep. My first question, Ron, is who are caregivers and what is the life of a caregiver? And I know that can take all kinds of meanings, but what does that mean from your perspective?
Thanks, Daryl. And kind of scared me. I kind of heard the paper shuffling when you're giving the list of my items. I don't think it was that long, but hello everyone. For me, first and foremost, I am a caregiver, as you can tell here. But there are many caregivers sitting beside you every single day. I know this audience here are small business owners, I think a fair bit, women business owners, and they're around you. They're your employees, they're your customers, they're your business partners, the businesses you deal with. Those are the caregivers that are around you. For me, I want everyone first to know that caregivers communicate through stories. Okay? That's something that you need to understand. We're not individuals that communicate with data, with transactional conversations. It's pretty much through a narrative that we communicate. For example, my dad had Alzheimer's for over 10 years, passed away at home, which was a huge challenge for my family to keep him at home. And I realized how difficult that was. But that's the work that I am interested in focusing on with the support of Age Well, with other leaders like Laura, to try and focus on the life of a caregiver to help someone age in place. For me, I'll throw out a few stats here in Canada, and this is from the Research on Aging Policies and Practice over at the University of Alberta back in 2014. So a little bit older stats, but it's relevant today. Caregivers comprise of 30 to 35% of the labor force. Okay, so approximately 1 in 3 of your employees, is a caregiver. There are 5.6 million employed caregivers aged 19 to 70 in Canada. Most work full time. 69% are women and 72% are men. And one stat, specifically maybe for this audience, a fair bit of women business owners, on average, employed women caregivers spend significantly more time providing care than men. Women would provide approximately 10 hours of care per week, while men are 7 hours per week. Okay, so those are the caregivers that are out there. On my end, I just want people to also be aware that the label of caregivers. Okay, many times caregivers don't even know they're caring. Okay, they don't use the term caregiver. There are other labels that some will use, maybe a care partner. Okay, outside of North America, carers are popular in Europe and Australia. And for me, sometimes it's just simply it's dad. I'm caring for dad. It's dad, it's mom, it's my partner, my spouse. That's really what a care is. And the bottom line is, if you care and you're giving some form of care, and everyone, I believe, is doing that right now. COVID has taught that to many people, what it means to care. That is a caregiver to me. And especially a life of a caregiver, just on that question there, the life of a caregiver, especially now during COVID, is quite challenging and for many has been very painful. Especially those, I know Laura talked about long-term care, caregivers caring for someone in long-term care. That's been a struggle for so many. In the home, caregivers are stressed. just trying to care more than they were caring pre-COVID. So that is kind of the life of caregiving. And it's not the same for everyone. Just like Alex said, we're all different, and it's different for every single caregiver out there.
Thanks, Ron. It's such an important thing to say. It's a caregiver is someone who is helping someone in need of care. And that's just about anybody who's doing that. How do we as a community, how did we do? And how are we doing currently with caregivers and their families during the pandemic? Busy time.
So this is even pre-pandemic. There's a word I always like to use when I talk about caregiving and aging in general. And it's not a bad word to me, okay, is fail. Okay, we were failing. We were failing pre-COVID, okay? And during the pandemic, it just put a spotlight. Laura said that earlier as well. This is not new, especially for those in the aging community and caregiving community, that we were failing, okay? My hope is that there's opportunities right now, and there is opportunities. I don't believe that we should waste failures. And an acronym I like to use that I have here is, every time you fail, that's an opportunity to find another important lesson, okay? And for me, the worst part of this is if we don't find those lessons and we don't act on that. So in my opinion, we were already failing pre-pandemic. COVID put a spotlight on that. And it is one of those where the pain points, okay, you can easily tell with caregivers is by inquiring about their emotions or paying attention to the emotions that they're dealing with. That's the core that I always assess. How are they feeling? Is their confidence low, or is their confidence high? Well, the confidence has gone down a fair bit, a lot actually. Are they fearful? Okay. And this is something, again, for businesses to be aware of, that, if you are trying to provide services or supports to caregivers, to understand what emotions are you solving for. So understand where caregivers are failing. We've failed a fair bit, okay? And again, there's pockets of opportunity right now through policy, through the healthcare system, and even for businesses, okay, to learn those lessons and move forward so that we can support caregivers and their families in the future, as we hopefully, in my opinion, we're going to be post-pandemic in the next while.
Thanks. You mentioned what we can do in terms of business. What can leaders do in terms of business, especially women business owners? What do they need to know about the world of caregiving and how it could affect their business?
So one thing is that caregiving is not just a conversation that's happening in the healthcare sector. This is a business issue as well, okay? This is for industry. Caregiving technically is a workforce issue, so that is something that we need to understand. And I know businesses love numbers, okay? So it's about the calculation of numbers, the returns. And I do want to share something on my end that I love to talk about. Alex knows this of me, that I do love talking about numbers. Okay, I do have an engineering background as well as computer science background. And I talk about the calculating caregiver, okay? That caregivers do a lot more calculating than they realize. A lot of conditional statements. If I invest in this service, or if I invest in this product, what is the return for me and my family, okay? So what are the ROs, the return ons, is what I'd like to talk about. The most popular one that everyone knows about is the ROI, the return on investment. That's very common. But let's take that to the next level. There are the ROTs for caregivers, okay? Which T for me would be return on time, okay? 24 hours a day for all of us, it's equal. But for caregivers, what kind of time am I using that? The quality of time that Alex was talking about, okay? Some people like washing dishes, but I'm just gonna give an example. Am I spending 20, 30 minutes washing dishes, or could I use, in my opinion, it's a robot, a dishwasher, okay? So that I could go and spend quality time with my dad, okay? So that's the ROTs. And there are many other ROs. There's return on time, but there's also return on the technology. Okay, what's the return on? Alex talked about a robot, and of course, in every Zoom meeting, sometimes a little pet comes through. Okay, now this is not a real pet. This is actually a robotic cat. Okay, what is the return on this? Well, for a family that I lent this to, it gave the caregiver at least 3 hours a day of respite, of rest. Okay, so that return on that technology provided a lot of time for that caregiver just to even take a break. But then there's other ROs, the ROQL, return on quality of life. Okay, QL could also be quantity of life. Ideally, you would like both quantity and quality of life. Return on the emotions is what I talk about. But in the end, the ROs, okay, it's different for everybody. Okay? And you're realizing that it's not the same for everyone. So I always leave it RO blank. You fill it in. Okay? For my dad, he loved music. He was a spiritual man. So can we give him some music and spirituality? In the end, that's numbers to me. Okay, so the return on the numbers. And if you ever forget this, okay, just remember return on the numbers is an acronym for RON. Okay, so it's actually my name. It just happened by accident. So what Ron likes to talk about is the calculating and the returns. Okay, and that's something that businesses should understand. How can you support someone with the returns that they're looking for?
Ron, absolutely brilliant. Just as an aside, how long has ROT and ROQ been around? I mean, like for me, it's really the first time I've really ever heard that used. Is it a
I don't know. I don't know if anyone else has done it before. I'd love to find that other person, but that was just me. That's how I actually did it when I was caring. I was, again, being a computer science, having a computer science background, it's all conditional statements. If I put my dad in long-term care, what is the return for that? Okay. If I keep him at home, what is the return on that? If I don't have one on me here, but put a remote camera in his home, what is the risk? Okay, well, yeah, there's ethical issues, security issues, safety, but then that return means that I could keep him at home longer. So that's just how I process things. But yeah, I don't know. If someone else has it, I'll give credit to them, but at this moment, yeah.
I think it's so wonderful because once again, and especially for you being a numbers person, it's beginning with a human concern, humanizing the process, and then using numbers around that rather than, as we so often do, especially when we're talking money, we talk numbers first. Wonderful. Can I ask you, how can, or maybe I could ask you, do you have any tips and suggestions for our audience of business owners and leaders when it comes to considering caregivers with their own businesses?
Yes, so you actually talked about it. Just you actually gave a hint here, which I don't think you even realized. As much as I'm talking about numbers here, okay, and returns, okay, for me, it comes back to being very genuine around the emotions and feelings of possibly your customers, okay, and your clients, or for your employees, okay? Because a reminder, caregivers isn't just what's in front of you, it's also beside you, okay? It's those that work with you every day. And some of you who are business owners are also probably a caregiver yourself. So, one of the tips I keep saying is understand the story, okay? Understand the story of where they're coming from and the emotions attached to that, okay? That's will speed it up for you to understand what the needs are, what the wants are, okay? It's something that if you have a business or a service that can offer compassion, empathy, the feeling of humor and hope, those are some of the emotions I look for when you're serving the caregiving community. So that's something there. In the dementia community that I'm in, there's a very popular phrase that said that the person with dementia may not remember who you are, but they will remember how you make them feel, okay? And I believe that wholeheartly, I've seen that all the time. But that's not just someone with dementia, in my opinion. That's everybody, okay? That's everybody who we interact with. So that is something that I really believe is important, is understanding the emotions, And then how do you convey that when you communicate it back to the families, the caregiver, or the caregivers that you're communicating with? Okay, come back in their language, and we will really see if you're genuine or not. Okay, in the end, we will feel it, and we will possibly even be a lifelong customer if that's something you're able to connect with us on.
I know we're leaving questions till the end, but perhaps I could run this one by. I just got a question here online, and I'm just thinking it'd be rather timely for you to answer that.
Sure.
Employment legislation has changed for providing leave for employees who are caregivers. How can we make allowances more reasonable, and especially providing some paid leave? I don't know if you've ever entertained that question. My guess is you've certainly talked to people who have. And thanks for the
yes.
question.
Yeah, thank you for that there. So that is actually important for this panel session here, that we're looking to see what happens afterwards. Okay, for me, I really believe that we need to be focusing on, especially with employers and in the workforce, supporting the caregivers a lot more. Okay, and that's first and foremost making employers just even aware, okay, of what it means to be a caregiver. Okay, there are many that are not, even though caregivers are sitting there with you silently. Okay, so a lot of them are afraid to share, what's going, if they share that they're a caregiver, that they might be let go. Okay, there have been many caregivers that have been let go just because they can't commit the time. I actually think it's the opposite, that the more you support them, the more they'll be quite loyal to you. Okay, so that is something that I really believe. So that awareness is first a big battle that we don't have going on. Smaller businesses can pivot easier, okay, but they may not have the support and resources to do that. Larger businesses, whether it's through their benefits plan, through their employment assistant and family plans, I believe we need to focus on that. There are some innovators, okay, that are trying to change that as well through tools and apps that might support businesses to allow the caregiver to, for example, to work remotely. And I'm saying that in a weird time right now. So I'm talking pre-COVID, but that they could be at work and they could, have a private place, an extra 15 minutes a day to remotely check in on mom or dad, or to communicate with that support worker or healthcare aide that's at home with my dad, right? But I'm not really answering the question, I think, here. But the point is that with policy right now and government, shifting the resources to home care and supporting even businesses, I really believe that is where we need to go in the next decade or so.
Wonderful, Ron. Thank you. And we'll look forward to talking to you as we close up here.
Sounds good.
Our next panelist is a former colleague of mine, and I refer to her as my best colleague ever. In my days at the university, we've spent many, many years working together, and that is Dr. Martha Dow. Martha is an associate professor in the Department of Social, Cultural, and Media Studies at the University of the Fraser Valley, where she is also director of the university's Community Health and Social Innovation Hub. Prior to joining UFE, Martha worked in government as a policy analyst in areas of social assistance, employment readiness, and child development. And she has worked with all levels of government, the United Nations, and with a variety of non-governmental organizations, and collaborating on over 50 projects, academic papers, book chapters, and reports. She has also served as an independent chairperson to the Solicitor General of Canada and as a panel member on British Columbia's Industrial Training Appeal Board. Martha is the recipient of the University of the Fraser Valley Teaching Excellence Award. Welcome, Martha.
Good morning.
Martha, I have a number of questions for you, and beginning with, what prompted you to become involved and ultimately lead the establishment of the Community Health and Social Innovation Hub at UFE, which you call Chassis, right?
Yes, yeah, great. Thanks, Daryl. As we get started, I thought in the spirit of the theme of humanizing healthcare, I wanted to honor that it's International Transgender Day of Visibility. I have to say that as I've listened to the tremendous subject matter experts and knowledge holders on the panel today, I've been reminded about the role of Chassis and what we hope to play in supporting our students and our community members on so many of the issues that have been talked about already. Daryl, as you know, I've been with UFE for 28 years now, and for all of my career, I've been involved in community engaged research. And I've always felt that my classroom practice was only as successful as I was able to engage students in terms of action, doability, a sense of urgency, and relevance in terms of what we do in our classrooms. So to your question, it was very clear very early to me that the concept of what would become Chassis was steeped in the characteristics that have always been central to my work, and I think have been so important in terms of a university education, in terms of educating citizens. So everything that Chassis does has to have a meaningful community partner. And we talk about partnerships, I think, pretty lightly too often. And so we use the word meaningful quite seriously. So it's not bringing an idea and then the university taking it away, as universities can so often do, and then, doing our work and then sort of informing people about what we did. But that's not engagement from our point of view. So it might be that they bring the ideas. So they might be involved from inception. There might be an idea brought. We start to bring other people around the table, but community partnership is absolutely fundamental to what we do. And then student engagement, same thing. We talk about students being involved, and I guess I can't use the photocopy example anymore, but we get students involved in tasks that aren't central to the work. That's not the case. Students are bringing ideas for work. They're engaged in, quantitative and qualitative analysis, development of instruments, all of those kinds of things. So that's key. So even though I've been engaging in this kind of work for all of my career, I really felt that our university, like so many, doesn't do enough of this really grassroots engagement. So I felt very privileged when our president asked me if I'd take the lead on establishing it, and now feel incredibly lucky, particularly during COVID, to work with such an inspiring group of people. So the idea came from the community, which we're really proud of. 3 divisions of family practice work with general practitioners in our community, brought the idea that said, basically, we think a regional university such as this should have a space, a physical space, and can't wait to get back to physical spaces, a physical space where research is happening, where that kind of incubator sort of approach is taken. And then the second piece of that for them was data. And the conversation initially was around data in terms of thinking about how we can merge, amalgamate, what kind of servers might hold, health data. That's how it came. As we talked more and more, Fraser Health came to the table. So that's our local health authorities. First Nations Health Authority was at the table from the beginning. The conversation morphed, I think, quite rightly, more into data sharing, data access agreements, those kinds of things. And then, of course, as COVID arrived, issues of privacy and health data have become even more pronounced than they already were. So I think that's a really important track. The last thing I'd say about that is the key issues from the community from the beginning were using language like nimble. They felt the need that when they came in the door with an idea, they didn't and couldn't hear that it was going to take months to develop the proposal, months to see if they could get approval, et cetera. Now, some need that, absolutely. Panelists have spoken to some of those kinds of issues. We've got tri-council projects that absolutely have a different project or a different process. So we were really attentive to being nimble, responsive, always closing the circle, and then knowledge mobilization. And we use mobilization. We do not speak about transfer. Transfer felt very unidirectional, still does. I've never loved the language. We still use the language far too much. So we, in many cases, as we all know, new work doesn't need to be done. How do we mobilize what's already there so it can be useful to people in our community who are trying to do such important good work? So I think those are kind of those key elements that we wanted to be thinking about as we did our work. We want to be inclusive and expansive in our understanding of sort of this idea of healthcare for individuals and communities.
Thanks, Martha. Chassis was established during the pandemic. In fact, I can remember very much when that was because I paid a visit to this center just as you were opening there in April 1st, 2020. And it was within weeks of the initial shutdown. And I couldn't help thinking to myself, I'm not sure this is the best timing here. But what has been the reception to the hub during these difficult times?
Yeah, I mean, I think there's such an appetite, again, as spoken about in different ways by panelists, to different ways of thinking and approaching some of the challenges that we have in our community. So that was pre-COVID, and it's certainly more pronounced. I mean, I'm not going to lie to you, opening your doors to a space that was to be collaborative and having people in there. We don't have any offices in our space. We designed it. The university did a great job, but they designed it so it was all open. I don't have an office. I sit at the table with my students and others, and community members come in. Well, obviously, none of that could happen very quickly. And while we worked with COVID protocol through the summer, in November with the greater shutdown, we moved remote. So yes, it's been a real challenge. Having said that, we have currently about 40 to 50 projects in the hopper. So those are in various stages of development. Some are already funded, just completed a couple of those as well. We're co-applicants on a couple of CIHR. So we've got that kind of big side of the house as well, that working with one of our research chairs around. And then lots of those real immediate community, we've had a community group come and say, we need this frontline position because we are deeply concerned about preteens who have suicidal ideation as an example. And we need a needs assessment to get some funding. And we're like, okay, how do we help? How do we dive into that? How do we bring students to understand that effort to be nimble? So it's been tricky given our concept, but again, we feel very privileged because I think we're also still able to engage in that very nimble, responsive approach that is even more, deeply needed during COVID. We've got a number of key stakeholders, as I mentioned, and they've been incredibly supportive as well. So tricky, but we're certainly seeing that the need was there, and we're responding.
Thanks, Martha. As you complete the first year here now, what have been some of the key challenges on your emphasis on an innovation through meaningful community engagement? Perhaps at the same time, you could talk about your focus on equity and access.
Yeah, I mean, I think that actually bridges them. So certainly the pandemic creates it, but I think the reality is that in a university, doing very out-of-the-box approaches to research and community engagement are quite challenging, right? The university is a very traditional hierarchical organization. And it was interesting, I was talking to one of my Chassis colleagues about this panel, and as he was looking at the diversity of people that were on the panel, he was really struck that he thought that what I should make sure we talked about is the entrepreneurial sort of nature of Chassis. So trying to look at health research in ways that are kind of that incubator, a startup kind of mentality. And that is not, in my experience, both as a student at different institutions and here, what universities do necessarily well. Now, in some sectors, they might. I think some business schools have thought about that differently. And some in science sector have done it differently. I come from the social sciences, less so. So I'd say, Daryl, that's part of it, working within a traditional model. So we've got to figure out ways to be more nimble when opportunities arrive. How do we move things through a process that needs budget, administrative fees, all of those things? We just looked at one community agency has $10,000 to do a pretty sizable piece of work. So we're trying to figure it out. Well, it doesn't work if a university takes $2,500 of $10,000 as an admin fee. Again, our senior administration has been incredibly supportive to try to figure out some of these pieces, but not easy. And particularly since universities are so used to moving through tri-council kinds of processes. So we need to figure out how do we make our institutions more receptive to this kind of collaborative work, even language, like, principal investigator, the focus on single authorship, order of authorship. We need peer review even. What does that look like when you're working in communities where the academic peer is one thing, but you want to honor the voices of those that you are trying to capture in the work? How could we be more expansive and creative around that? So I think that's important. And we can do that. It's called transparency. If I do a piece of work and I am transparent about how we did it, how we navigated the methodology, that goes a long way to be able to respond to some of those narrow lanes that sometimes we have to drive in. So, and certainly that admin piece, compensation for people, those models need an innovative approach as well. Developing relationships with vulnerable populations who are leery of institutions like universities, have had their knowledge taken and not felt that they were a part of that. So I think that's an ongoing challenge for us, as you've described. And then finally, like a greater appreciation for community-based research. It's quite amazing still how many walls we run into in terms of doing this work. So again, the good news at my institution is that our president, our provost, our AVP research have all really been trying to figure out creative ways to do the work. So that's very exciting for us.
I'm mindful of our going over time here, but if I could just squeeze in one last question with you with a very quick answer, because I think it's an important one. You've said, by its nature, innovation necessitates strong leadership. What do you mean by that?
Well, yeah, I think it's one of the most important questions we have to consider right now. I think I haven't met many leaders in my career who I classify. I think we often talk about leaders, and what we mean is that they are decision makers. They have power to make decisions. So I think transparency, accountability. We don't have to look very far these days in BC to watch how individuals with decision-making power are not taking on accountability during these times, looking outward, blaming others for situations. So I think accountability, appreciating science and evidence in a really meaningful way, not lip service, I think. And then I'd say humility and the ability to inspire others to engage in innovation and creativity. There's no more important time for this kind of leadership. So those have become some of the pieces I would point to.
Wonderful, Martha. I'm so thankful you're doing what you do. University as always. Our next panelist is Dr. Angela Marshall. And Angela is a board-certified internist and fellow of the American College of Physicians and the founder of Comprehensive Women's Health, a thriving primary care practice for women with 2 locations in the Washington, D.C. area. Beautiful city, by the way. Angela began her career, if you can believe this is a switch, no pun intended, as an electrical engineer for the CIA. She goes from there to medicine. Although she enjoyed the field of engineering, she decided to combine her love for science and passion for helping people by pursuing a career in women's health. Throughout her medical career, Angela has impacted the lives of thousands of women by promoting a style of medical practice that emphasizes patient-centered emphatic listening. She currently chairs the board for Black Women's Health Imperative and is a staunch advocate for achieving health equity for medically vulnerable populations. Angela has been repeatedly named top doctor by Washingtonian Magazine. Her awards include Maryland Top 100 Women Award, Enterprising Women of the Year Award by Enterprising Women Magazine, and Smart CEO Magazine's Bravo Award and Circle of Excellence Award. Angela, thank you for being here. My first question for you, Angela, is 10 years ago, you adopted the patient-centered medical home model for your practice. Can you tell us what being a patient-centered medical home means to you?
Absolutely. Thank you for having me. About a decade ago, we adopted the patient-centered medical home model, and we were able to achieve NCQA recognition for it. And NCQA stands for the National Committee on Quality Assurance. And the patient-centered medical home model is exactly as its name suggests. it actually puts the patient at the center of everything that we do, which has been really helpful and appreciated by our patients, particularly our women patients, because women tend to be the healthcare navigators for entire families in many cases. The World Health Organization estimates that there is a shortage of about 4.3 million physicians, nurses, and healthcare workers worldwide. And so what we've learned is where there are shortages, there are often access issues. And when there are access issues, oftentimes it puts the healthcare providers at the center of the healthcare equation, meaning that we see you when we have time versus we see you when you need to be seen. And in the vaccine example that Laura brought up, that's another example where there's a shortage, it creates access issues. And so instead of giving the population vaccines when they need it, we give vaccines when we have it. And so it's really important, I think, when we talk about healthcare and the way healthcare is delivered, that we are mindful of this model. And the PCMH model, the patient-centered medical home, really does meet the patient where they are, and it really strives to give a more holistic model of care, and our patients really appreciate that.
Wonderful. I have so appreciate that, because in the university, of course, we talk about student-centered learning. It begins from the student outward. You shared with us how important it is to be listening in patient care. Why is listening so important when it comes to patient care? And I'm thinking in answering that, you could speak to a good number of practitioners out there, because we often hear patients complaining that the doctor is not really listening.
Absolutely. You know, I think as a doctor, listening is one of the most important things that I can do for my patients. And there are many reasons for that. But number one, research has shown that over 90% of diagnoses can be made by the history alone. And so if you don't listen, you're not going to be able to make an accurate diagnosis. And so I think also listening helps to counteract bias, because as doctors, we're human. And sometimes when a patient says they have chest pain, we immediately go to, okay, are they having a heart attack? Well, if we don't listen to the rest of the history, we may not make an accurate diagnosis. And so listening is really important. I think we've also learned that listening is important in the field of telemedicine. We've now been using more telemedicine and had to rely more on listening than we've been relying on technology and diagnostics in healthcare. And so I couldn't emphasize this enough. I think another reason listening is important is because many times patients want to be heard, but they also want to be validated. They want to be validated. And so when we're not listening, oftentimes when patients come in, their chief complaint is not the chief problem. And so sometimes they may come in for one thing, but there's something else that's underlying their concern. Sometimes it's an anxiety about something. And so if we're not listening, we miss out on being able to give a reliable and accurate diagnosis. And more importantly, oftentimes the patients leave and feeling like they weren't validated or feeling like their concerns weren't addressed.
Thank you. Another question for you: how does reimbursement get in the way of delivering quality care, and especially as it relates to seniors care?
I think that's a great question. Reimbursement is so complicated, and it really does complicate the doctor-patient relationship. You know, in most businesses, you have the business that offers the service or the goods, and you have the customer who pays for those services or goods. But in healthcare, we've got third parties that actually pay for the service. And oftentimes it complicates it because it puts that third party in between the relationship between the doctor and the patient. And, you know, in the US and Canada, you know, insurance is very expensive. Healthcare is very expensive. And so I think it's important to talk about reimbursement. As Laura mentioned, you know, a lot of times we're paying for more acute episodes of care. And speaking of episodes of care, at least in the US, we pay for when we see the patient. So the healthcare is paid by episodes of care, and all the in-between care is left uncompensated. And so it makes the patient feel like they're not really cared for in between those expensive episodes of care.
Thank you. What advice would you give doctors who treat patients in today's healthcare climate?
Well, the advice I would give is we need to bring professionalism back to the field of medicine. I think we've lost a lot in the area of professionalism. I think we need to bring honor back to the profession. And I think we also need to really understand the profound duty that we have as physicians, and that we are caring for patients when they're in their most vulnerable state. I think we also need to encourage self-care of physicians, because when physicians are burned out, stressed out, maximally spent, we're unable to deliver the quality of care that our patients deserve. And so I think it's really important for doctors to also practice self-care. And again, I couldn't stress this enough. I think it's also very important that we practice patient-centered care.
Thank you. You know, I know your name's Angela, but I'm sometimes thinking that it should be Angel. Your perspective is so wonderful. Can I just ask you one last question? What is one key way that healthcare providers may deliver a more humanized patient care experience? And I think you've already alluded to some of that already.
Yeah, that's a great question. Well, first, let me say that I think with this pandemic, we've had a proliferation of technology, telemedicine, and I, as a former engineer, I love the fact that technology is finally infiltrating the healthcare space. And so I love technology. But on the other hand, we have to make sure, as Ron mentioned, that we're not missing the human component. And so for doctors, I think it's important for us to sometimes put away the computer, stop for a moment, look in the patient's eyes and speak to them directly, and really make an effort to connect with our patients, calling them by name, making eye contact. I think those are the human aspects that we must not forget as we're relying more on technology to deliver healthcare.
Thank you, Angela. We'll look forward to talking to you as we close.
Thank you.
Our final panelist is Carolyn Cross, and Carolyn is the founder, chairperson, and chief executive officer of Ondine Biomedical, a Vancouver-based med tech company that is the global leader in photodisinfection-based therapies for the treatment and prevention of multi-drug resistant infections. Carolyn also sits on the National Research Council of Canada and is the chair and founding board member of the Women's Economic Business Advisory Council. And she is a founding member of the EY Global Women in Business Advisory Council. Karen was awarded the Meritorious Service Cross by the Governor General of Canada and is a recipient of numerous awards, including the Queen's Jubilee Diamond Award, the President's Award from the Women's President's Organization, the Wendy McDonald's Enterprise Award from the Vancouver Board of Trade, and the Innovation and Global Growth Award from the BMO Financial Group. And you are, bar none, one of the smartest people I have ever met. I'm thinking back to the times we've had lunch together. You are such an interesting person to talk to, Carolyn. I've got a few questions for you. Why is infection control so important to this country?
I'm going to talk about three things. Anywhere. Well, in particular to Canada, and I'm going to borrow from some of the themes that came up from just the recent panelists. One, there's no slack in the system. So we hit this crisis without the capacity. Two, we're way too dependent on foreigners. for our supplies, for our drugs, our medical equipment, for vaccines. And when there was supply chain disruptions, we're impacted. Hence, a D- in our vaccine efforts. And then finally, this is more of a global issue, is that we've got a rising problem with antimicrobial resistance, or bugs that there's no treatments for. And that is something that we're just not spending enough time, energy, or money or focus on that emerging problem. So let's put this in perspective. Antimicrobial resistance is it currently takes about 700,000 lives annually at this pace. It is increasing by 30 years from now to 10 million deaths a year. Put that in perspective, COVID has taken 2.8 million global lives. So we're going to have 3 times COVID type of death rates in 30 years from now. And at that rate, that takes up 2% of Canada's GDP. And we already don't have the slack in the system with an aging population. So infection is a really important matter that we need to get on top of now, especially when we can prevent many of those infections, whether it's early steps, better hygiene, better vaccination processes, better education. There are some easy remedies that don't cost a lot of money and can save us a lot of unnecessary resources and stress on families.
Thanks. You've had some success, and I say that, I know I'm saying it as an understatement, with your technology, both for reducing surgical site infections and during COVID-19. Can you tell us about some of those examples?
Sure. Well, first of all, our lead product is able to clean bugs out of the nose, any bugs. So when the COVID crisis hit, we were able to regroup and said we could reduce the viral load. And if we do so, people are less likely to get sick. So we've been able to demonstrate that our photodisinfection technology is able to eradicate in minutes the SARS-CoV-2, the coronavirus, very easily. And then we've been able to work with some doctors that are out in the Canadian environment who are familiar with our work in hospitals, and I'll get to that in a second. And some of these people have started deploying the technology. And in one case I'll mention is a meat processor who started deploying back in the summer, concerned about the second wave, knew it was coming, and proactively adopted our technology into an overarching PPE and hygiene plan, and was able to prevent any outbreaks of COVID in his facilities. That is the only meat processing plant that we know of in North America that was able to do so. And more recently, although very early stages, a Toronto clinic has been converting negative patients that have come in positive for COVID to negative for COVID. And that's early days, but we're very excited about that prospect. But I did mention that the big successes we had with our technology are in hospitals. We've been in hospitals in BC for about 10 years, and we've been able to reduce hospital-acquired infections, surgery infections by about 80%. And what I'm proud to say is that we've spared about 1,000 people and their families and their employers, et cetera, from having major surgery infections. And that has saved at least 5,000 beds, more than $30 million, and also has been the equivalent, if you think about it, of 2 jumbo jet planes full of people. And that's just kind of a really cool statistic for me to think about.
It's so inspiring to hear about those successes, and I say to myself, why isn't this in every hospital on the planet? which I guess is a good lead into my next question for you. What are some of the challenges you face in bringing innovation forward? And what are your thoughts on why that might be so?
Obviously, I've spent a lot of time thinking about this question and get that question almost in every single case and conversation related to our technology. As it relates to COVID, this one's probably the easiest. There are limited resources and limited time and limited people. So the government and healthcare providers really focused resources and attention on two things, PPE and vaccine. And just about everything else had to be put on the shelf. There's a lot of solutions floating around, and our technology and others just got lost in that shuffle. So that's an easy answer. The longer term, more general answer is something that Canada has to address. And the issues are that there are too many gatekeepers. It's not one healthcare system, it's many healthcare systems. And healthcare systems that are themselves struggling. Insufficient capital and budgets for all of them. Haven't figured out a way to really communicate well with each other. Federal government, provincial government, and then regional hospitals and then clinicians. So there's too many gatekeepers that are not able to make decisions. So decisions are stalled. Number two, there's a bias against innovation. If you know you've got this wall of, conflict and challenge of getting innovation and new protocols and new cost-saving measures through and listened to and supported, you're not going to really try. So we don't reward, unfortunately, the champions in our healthcare system with recognition or money or bonuses or anything for innovation. So we are biased against innovation. And this actually does make sense, because if you are driving a car, which we kind of talked about, that's falling apart, and we're asking it to go faster and take on more passengers, the last thing you want to do is ask it to change out the tires. And so if we really look at that image as what's going on in our healthcare system, it will help us. We have to admit that we have a problem. And as a society, we don't want to touch that, that sacred healthcare, socialized healthcare issue. We're the only, I think, last remaining OECD nation that doesn't have a private care faction to help support the costs. There's also a bias against Canadian SME, small businesses in particular. So if we're having a system that's really focused on trying to make every dollar work, they're going to go for large bundled contracts. And little Canadian companies cannot get into and unbundle those contracts. And that's why we came into big difficulties, and there was no Canadian PPE suppliers. And then if you don't have Canadian technology or Canadian domestic market, it's hard to build up scale and reduce costs in export markets, because they will say to you, well, what are you doing in home? If your product is so great, why isn't this all over Canada? So it's difficult from an endorsement perspective to sell outside without that domestic support. And then the lack of access to Canadian facilities and dollars, that is huge. So for our own example, we're saying we've got probably the world's best topical antimicrobial technology that's been proven safe for 10 years. We don't have to reinvent anything. Just let us access that BSL-4, BSL-3 facilities to show everybody and ourselves that this can be killed using the same thing that's being used in hospitals every day. And we couldn't get access because they were focused on vaccine and other development work. So being shut out of tax-paying Canadian institutions and facilities is a big challenge, especially for Canadian innovators. And I want to also mention that Canadian innovators are private sector. Innovation comes from the private sector. Science explains it. Science improves it. But innovation really comes from the private sector, and the private sector is chronically underfunded, especially in the innovation space, and especially gender. Women-owned businesses are 5% of the capital. So you've got the triple whammy of innovation, gender, and Canadian biases that provide some of the big challenges to get the capital and the resources, and therefore the talent you need for technologies like ours. That's a good list of challenges, I think.
I think you've pretty much answered this de facto. It's just that, was another question I was gonna be asking you is would you recommend we do to improve health innovation in Canada? And I guess you could start by saying, well, quit doing things which aren't helpful, which hurt innovation. But if there's just one thing, and we're really running low on time here, but in a nanosecond, if you might just give us a snapshot of just what you would most recommend.
I think our panelists have already covered quite a lot. So I would say we have to admit as a society our system that was designed in 1950 when it came out for lifespans that were going to end at 67 doesn't work for us today. And we need more diverse groups like Chassis and more panels like this. Thank you, Barb, for organizing it. And more business voices on those panels and in those discussions to round out and get to the solutions that are needed. And then we have to politicize this to give our elected officials the right kind of support to make the important decisions that are going to be necessary and painful, and good decisions that are going to be necessary. And it's got to come back to patient-centric. So I love Angela's and also Ron's and everybody's viewpoint on that. So there's others, but I'm going to leave it at that.
Okay. So I was going to have another question, but I think you can incorporate it under a question that I have for all of the panelists. And with that, maybe I can begin with Carolyn on this one before moving back to Laura, because, just to finish up your points there. And the question is, if there's one single thing government should or could do to improve our capacity to provide for better healthcare going forward, what would that one thing be? That's a big question.
I would say better future planning. Think 5-10 years out, and we start with what that looks like, then we can work backwards, and then we will be at least moving in the right direction.
Thanks very much. Laura, can I ask you that question?
There's kind of a high level answer and a really tactical answer, and I'll indulge myself by taking the high level answer is to stop thinking in segments and actually think about aging broadly and what is it that we need to do. And the good answer is that we actually know what we need to do. So it's a matter of prioritizing doing it. So we know we need more investment in home care. We know that we need to support flexible regulation and things like dementia villages. We know that we need to incorporate technology. Like, we know all these things. So it's just a matter of starting to do it. At a very minor level, I'm going to push on adult vaccinations because that is such an easy to do thing. And we very much already have these vaccines well in hand. We need to just amplify and support getting that vaccines into the arms of people, not just COVID-19 vaccines, but preventive health vaccines that are already part of our schedule. We just need to do a much better job in getting that as part of our regular preventive health schedule.
Thank you. Alex, can I ask you that final question?
Yeah, I think.
What is the one thing government could or should do? Go ahead.
Yeah, I think just building off what's been said already is ensuring the infrastructure is there for these technologies and innovations to be able to be used. It still amazes me that I still go to care homes and there's no Wi-Fi, in the home. And that can make such a huge difference. And so really, this government and others really need to take the mentality that access to technology, access to digital health is a basic human right. And that needs to be implemented as quickly as possible and not 10 years from now, as is the current plan with respect to the government.
Hear, hear. Ron.
Yes. So for me, Laura hinted to my answer there, which is transferring more of the resources and services, the numbers, which is usually dollars, over into home care and into the community. That's what I'd be looking for, and I'd be pushing a fair bit. I think you're going to get a higher impact with humanity in our population and healthcare specifically, if we can find, it's not about finding, as Laura said, the answers are already there. It's just a question of will government and policies and the resources shift over to the areas where we know it will give a higher return. So that's my answer, back into the home care and into the community, the resources.
Thanks, Ron. Martha.
Well, everything that's been said, I agree with, I guess, and I'd say, given what we know, do better. I mean, I couldn't agree more that we know so much and we just don't do it. My students always say, I'm always saying in class, given what we know, we shouldn't do that. Like, that's how I talk about public policy. But so yeah, that's what I'd suggest. And I think understanding health, individual and community health more holistically would go a long way toward that.
Thanks, Martha. Angela.
I think both of our governments, as well as insurers, should shift resources more towards preventative care than acute care, because on average, preventative care costs about 1/10 of what acute care costs. And I think we'd save a lot of money by just shifting those resources where it's going to have the greatest impact.
Thank you. I guess, just about to make a quick closing remark before I turn it back over to Barbara. And of course, if there's an outstanding question that somebody in our audience has, we perhaps have time to consider one or two of those. But before I do that, is there anyone of you as panelists who have one last point that you think needs to be made? You're certainly welcome to do that now. No? Okay.
I will always take the floor for seniors. I mean, I think what you're hearing is from experts across this country and internationally saying really that there's a high degree of confluence. A key challenge is governments don't work that way, right? Preventive health is not a thing that they have quickly on the agenda. When you're thinking about election cycles, you're not thinking about saving dollars in future, you're thinking about what's on your budget right now. And as the Canadian context, we're having a federal budget drop in about 19 more days. The question will be, how will we see older adults reflected in that budget? We have seen historically in Canada this kind of pointing around the division of powers, but the division of powers was never created to avoid looking at issues. It was created to ensure coverage of issues. So from the Canadian context, there is an opportunity to be transformative with this upcoming budget. But the question will be, will this government rise to the challenge? And I think what we know is that colleagues like we have today need to also be supported by members who are, participating in our sessions today. We need one voice to say, this needs to be a seniors budget. This needs to be an aging budget. This needs to be a budget to actually address these issues. The time is over now. We're done. We need to move forward.
Thanks, Laura. I've got a couple questions here that, from our audience, and I'm hoping we can get through. Well, I hope we can get at least through a couple of them. And one is, with respect to vaccinations in British Columbia, why do you think many pharmacies are not being used as they are in other provinces? Well, what should be done about this? I'm thinking as a test, as of today, as we're sitting here now, I know at least one pharmacy chain, Shoppers Drug Mart, is is starting to administer vaccinations on a test basis, I guess, if you will, at least the one near my home. So does anybody have a comment about that? Like it was kind of a surprise to me that pharmacies weren't used as they are for vaccinating people for flu. Does anybody provide an answer for that? Should I pick on? Oh, yes, Carolyn.
I was going to suggest that the issue would be of control and to make sure that there was this fair and equitable distribution. But that is questionable. I mean, one of the failures is where are the distribution points, and are people actually able, back to this access issue, to get there? So controlling fair and equitable distribution would be my guess why they didn't do the obvious thing to go to the existing vaccine distributers.
Now, can I ask this question? I have a question that was, oh, go ahead, Laura. Go ahead.
There's a little bit of a lag time. One of the pieces I think that's really important to remember is that the rollout has been done provincially. So many jurisdictions have been using pharmacies, and some have been using some pharmacies in some other centers, and then some are a bit slower. So BC historically has an abysmal vaccination coverage rate, and has, if you look at our vaccine report, you will see that it is one of the worst provinces for both hesitancy as well as funding. So there is a historical provincial problem with British Columbia and vaccination rates. You know, Dr. Alison McGeer, who is a leading epidemiologist and immunologist, said something at the earlier points of the pandemic, and I think it has ever proven the case. She said one of the key challenges is we're thinking about COVID-19 vaccine distribution as a logistics problem about vaccines, and it is not. It is a vaccine problem with some logistics. And so some provinces, and I'll point on Ontario because I know that we have a couple of our members here from Ontario, you know, we saw that General Hillier came in and read this sort of idea of military precision and so on and so forth, and really built out an entire extra superstructure around vaccine uptake, much to the bafflement of people in public health who say, you know, get it to the doctors, get it to the nurses, get it to the public health units, get it to the pharmacies. We know perfectly well how to do vaccine uptake and reform. The piece that we need you to add it to, logistics people, is drive-throughs, mass clinics, and mobile units. Those are the areas that we need a bit more innovation. And yet what we've seen is a real disconnect between using, in some jurisdictions, again, British Columbia and Ontario are two that I would point out, of creating very narrow structures when we should be having them wide open. Nova Scotia, where I am today, has been using the broadest number of structures, including mobile units, including drive-through, including, you know, convention centers, and at the heart of it, community-based pharmacies as well. So it is really a difference provincially of strategy.
So thanks again, Laura. Maybe I could just squeeze in one last question here. There's others, but I'm just going to choose one here. Because it's right up on my screen at the moment, and that somebody is asking what COVID has taught each of you. And I guess the other part of that question is, if you were the Prime Minister, what would you immediately change? Certainly, you've heard lots of discussion about that. Now, again, if you could kindly just try and answer that. It's almost impossible. But in a sentence or two, what would you change if you're Prime Minister? Or I guess, Angela, for you, if you were part of the President's task force. So can I start with Ron?
For me, it's back to my answer earlier. The role, I believe, in his position would be to shift the resources. For me, just moving the resources where it's more impactful in the home environment, which is where I think it needs to go towards.
Right. Thank you. Alex.
That's a tough question. I've been sitting here thinking about it, and obviously I can say the obvious thing, that is, put more support towards the role of technology and innovation into everything. But my honest answer is stop believing that the Canadian population is so naive about these things, and actually take into account, as Laura, Martha, and others have pointed out, that a lot of us already know what we're doing in this area, and resource the knowledge and the intellect that's already in this country that could have moved this thing forward a lot quicker and more efficiently.
And Martha.
I'm actually just going to say yes, Alex, to be honest, in the spirit of time.
Yeah, I'm just thinking this is a difficult question, because as a politician, I would say, can you say that in half a sentence? And as an academic, I would say, are you crazy? That's going to take hours to answer that question. Angela, can you provide an answer to that?
Yeah, so I know I talked about the patient-centered model, but I think it's also important to focus on the care of the health of the population. And so the population's health does matter. And so I think we need to focus more on the health of the population, not just for the year or the budget for the year, but the overall health of the populations.
Thanks again. Carolyn.
I would say that we need to use Canadian procurement healthcare budgets to build up Canadian capacity, so we are self-reliant in many more of our essential medical equipment, drugs, vaccines.
Thank you. And we'll just finish up again with Laura. We'll pick on you again, if you may.
I would support and fund national long-term care standards and tether federal funding to the provinces for implementation of those standards. And I think we will be watching closely on April the 19th to see whether or not that comes to fruition.
Okay, again, I'm about to turn this back over to Barb here for closing comments, but I just want to thank you all profusely for your responses and your willingness to participate in the first instance. I just find it so inspiring. And I know all of you have so much more that you could say. I just want to thank you for managing to squeeze it in under this, the confines of, what we have available to us here in this 2-hour period. But, best wishes to all of you on what you're going to be doing in the future, because I just know that whatever you're doing is helpful to all of us. It's very, very much appreciated. So thank you. Barbara, if I could turn it over to you.
I'm here.
Yes.
I am here. And please, panelists, can you just stay on for a few more minutes so I can just thank you again. I can't believe what an amazing panel. Thanks to Angela, Alex, Carolyn, Laura, Martha, Ron, and of course our moderator, Daryl. Superb job. As thought leaders, you truly continue to inspire new ways of thinking. Your work and your advocacy in healthcare is not only innovative, but encouraging for all societies. We actually have over 109 registrants for this session. They are not just Canadians or US people, they are global. We have people from different parts of the world right now listening. And so I want to thank all of you whom I trust, all of the participants, wherever you are, whatever time zone you're in. I trust you're all energized and filled with new knowledge from wonderful citizens, all our panelists, our all-star panelists, who want to make healthcare better. And isn't that Joe Biden saying, just be better? I realized that after I wrote it, but it is just be better. I encourage you all the participants who listened in today, to use your voice to influence change. It is both a private and a public sector problem. And we all know that crises does bring opportunities. It is important that we listen to Secretary General Antonio Guterres, who said, together we need to listen, and together we need to act. Laura, I could not agree with you more. I'm going off script here. BC is dismal right now for our vaccination program. And so it's like, what happened to us? And I can't speak for Ontario, but I certainly have relatives there too. So I want to thank all of you for your very honest comments. I wished you were all had the chance to be one day the Prime Minister. I also want to thank you, Angelica, for your welcome and the incredible team at Hubcast. Peter, Delan, Adam, Stephen, Christian, Jordan, and of course our Accelerate team, Nadine, Alicia, and Janice. Please, this will continue. With all of your permission, panelists, there will be questions that that the registrants want to send to you. And I hope that we can capture a lot of what you said in sharing your voices. Please don't forget to give us your feedback while it is fresh in your mind. We truly value all your comments and we need all the evaluations. You will see the link on Event Mobi, our social platform. Now, let me just take a couple of minutes to share what's coming next, because all of the panelists can send it to your friends and colleagues. First, mark your calendar for the April events. We will have 3 amazing sessions in April. So book your day now so you won't want to miss these speakers. They are all-star panelists like we had today. Starting with Up Your Speaking Game to Attract New Global Opportunities, hosted by the Organization of Women in International Trade. We will have speakers and take tips from Canada, Africa, Europe, and USA. Another session will be with Addie Greco-Stanges on Build Your Resilience, 5 minutes at a time, an amazing session and an amazing author. And then we'll end the day with something that is important to all of us called Sustainable Solutions, where international speakers from Asia, Africa, Canada, and the USA will share how women are creating smart solutions for sustainable success, addressing climate action, world floods, mental health, peace and security, racism, and much more. Again, an all-star panel will be speaking. Please share with your networks to go to www.accelerate 2021 to sign up for our upcoming sessions. And remember, there are many still outstanding speakers, both not only in April, but May, including celebrating our 10th year of Grow Your Biz, where we will be announcing our Grow Your Biz Awards, our finale, with Pamela Martin, our Mistress of Ceremonies. Hashtag us, hashtag Accelerate 2021. Thank you for your participation. And I look forward to seeing many of you in April and May. And again, panelists, please, we will add your comments wherever we can to social media to advocate and to be an advocacy for what each of you have said. I took so many notes down, even though I knew some of the questions, you were all stunning. Remember to evaluate today's session. And Daryl, I already got comments. What a great moderator you are. Yay, and thank you again.
Thank you, Barbara.
Everyone. Bye for now.
Bye now. Bye, everyone. Thank you.